So for, I'm seeing some other things in there. Oh, something with that slide. So for this one, we're going to have some other cases that are related to acid-base in our session on cases later in the afternoon. So for now, we have three main goals for this talk. One is to have a framework for interpretation of acid-base disorders. That's a short question on your boards. It's there every year when I take those modules. So knowing how to just say what the disorders are following a certain presentation is something you should definitely spend time doing. And then we will review the sequential approach to the diagnosis of both metabolic acidosis and metabolic alkalosis. So the case. Previously healthy 32-year-old man is admitted with fever, abdominal pain, and diarrhea for the previous 5 days. He's on no medications. On exam, he's minimally arousable and hypotensive. His abdomen is diffusely tender. Laboratory tests show a sodium of 130, potassium 2.8, bicarbonate of 8, chloride of 102, and an ABG with a pH of 708 and a PCO2 of 28. Which of the following best describes his complex acid-base status? A high anion gap metabolic acidosis with a respiratory alkalosis, a normal anion gap metabolic acidosis and a metabolic alkalosis, a normal anion gap acidosis, a high anion gap acidosis, and a respiratory acidosis, a high gap acidosis, a metabolic alkalosis, and a respiratory acidosis, or finally, a high gap acidosis, metabolic alkalosis, and respiratory alkalosis. Believe me, this is a question that will be on the boards. Well, obviously, 10 seconds is not that much to think it through, but only 20, what do I see? Right in, only 20, what is it, 20, I can't see very well, 20-some% got the right answer. So we're going to, over the next few slides, we'll review the steps, and then we'll get back to the case. So, approaching an acid-base disorder. Think about the clinical scenario. For any clinical scenario, you will be able to come up with something that should have an impact on acid base. So for example, the guy with diarrhea, losing bicarbonate, a non-anion gap metabolic acidosis. Someone who's sedated, a respiratory acidosis. Someone who's hypovolemic could have a metabolic alkalosis, but if the hypovolemia is enough to cause hypoperfusion, a lactic acidosis, a high anion gap acidosis. So just based on what this guy had, diarrhea, sedation, hypovolemia, and hypoperfusion, you could already guess that he would have maybe a non-gap acidosis, maybe a gap acidosis, maybe an inappropriate respiratory compensation, so a respiratory acidosis, and perhaps an underlying metabolic alkalosis. So those are the possibilities. The second step is you look at the BMP, and if you see an abnormal bicarbonate or a high anion gap, there is an acid-base disorder. You need to go find it out, okay? Sometimes those are normal, but in most cases when there is an abnormality in bicarbonate or in the anion gap, you have to go look for an acid-base disorder. And finally, you have to look at the ABG. There's no intelligent discussion about acid-base disorders without an ABG. And the ABG is going to be important to first define what the primary disorder is, and that's the pH. If the pH is acidic, the primary disorder has to be an acidosis. Whether it's metabolic or respiratory is up to be defined, but the primary disorder has to be an acidosis. And then it helps you define if there's a second disorder. And the first way you do that is by evaluating the compensation. And that's what this slide gives you. It gives you what the expected compensations are for someone who has different metabolic and respiratory disorders. So you don't have to keep this in your mind, but you need to know that they exist, and so that you can calculate how much of what you're observing in terms of compensation is appropriate or not. The other thing that's useful to keep in mind is that compensation rarely normalizes and never overcorrects. And the only one that really normalizes is chronic respiratory alkalosis. The bicarbonate can drop enough as to normalize the pH. But usually it doesn't normalize. It stays still below normalization. And the other thing is that there are some limits of compensation. So, for example, for metabolic acidosis, the PCO2 rarely goes below 16. If it's going below 16, you've got an associated respiratory alkalosis. In metabolic alkalosis, the PCO2 essentially never goes above 55. If the PCO2 is above 55, there's associated respiratory acidosis, so on and so forth. So looking and keeping in mind these limits of compensation is useful to make you think if there is another disorder associated with the primary one that you have. The second step in looking at whether there is a second disorder or not is looking at the anion gap. And the anion gap has the following implications. If you have a very high anion gap, arbitrarily greater than 25 to 30, you know that an organic acidosis is present. You got to go find it, okay? Whether it's lactic, whether it's ketoacid, or one of the less common ones, but you got to go look for that. In patients who have very severe acidosis, so defined as a bicarbonate below 8, even lower anion gaps also always make you think of an organic acidosis. And then finally, a caveat that you may see an anion gap in the 15 to 20% in severe alkalemia, especially chloride responsive alkalemia, so volume depletion. Okay, so just remember that as a caveat. But in the other two, very high anion gaps, there's always an organic acidosis. And an anion gap that's even borderline-ish, 15 to 20, not that high, is always present if you have very, very low serum bicarbonates. And then finally, we have to ask if there is a third disorder. And one of the simple ways to look, and even though there are lots of problems with the delta change, or the change in bicarbonate and change in anion gap, physical-chemically, there are lots of problems with this, but from an educational perspective, I still like to use it. And here's the concept. When you add an organic acid, there's a change in anion gap, so the anion gap will increase, and there'll be an approximately equimolar fall in bicarbonate, okay? So understanding how much the anion gap is increasing compared to baseline and how much the bicarbonate is decreasing helps you sort out if there's a underlying disorder before the organic acid was added. And the way you calculate that change is you take the change in anion gap, you do what's observed, and you subtract 12, which would be sort of the upper limit of normal. And the change in bicarbonate is you start with 25, which would be the approximate normal level, and you subtract from that the observed one. So let's look at the interpretations of this. So let's say you have a big change in gap without a very big change in bicarbonate. That's probably someone who has an underlying metabolic alkalosis, someone who was walking around with a metabolic alkalosis, so the bicarbonate was high, and then had an organic anion added, let's say diabetic ketoacidosis or lactic acidosis, and the anion gap increased a huge amount, but the bicarbonate that you're seeing doesn't look as impressively low because the patient started at a higher bicarbonate. On the other hand, when you have a change in an anion gap that is much less than the change in bicarbonate, then you think of two options. One is that the patient has a high anion gap, which is the new one, superimposed onto a non-anion gap. So let's say someone with chronic diarrhea or with a chronic renal tubular acidosis who then develops DKA or lactic acidosis. So you're going to see this anion gap that doesn't look too impressive, maybe an anion gap of 20, but a bicarbonate that looks awful, let's say a bicarbonate of 5. So that would be one of those. The second possibility is that the bicarbonate was low at baseline, not because of a normal gap acidosis, but because of chronic respiratory alkalosis. Let's say a cirrhotic patient or a pregnant woman who lives at a bicarbonate of, say, 17 or 18, who then gets a high gap acidosis on top of that. So those would be the three ways of interpreting these changes in an ion gap and in bicarbonate. The different types of mixed acid-base disorders are in your handout. They can be additive, counterbalancing, or triple. And you can look at the different examples, but the important thing to remember is that when you add a metabolic acid to a respiratory acid, or a metabolic alk to a respiratory alk, you're going to see these very severe disturbances, very low or high bicarbonates, very low or high pHs. Whereas counterbalancing ones are the subtle ones, are the ones that are sometimes difficult to catch, because there's a respiratory disorder pulling in one way and a metabolic disorder pulling in a separate way. And finally, the patients who have triple disorders, and those are the combinations of having something underlying and then two new processes superimposed. So getting back to the case, the patient had diarrhea, stupor, hypotension, was hypokalemic, had a high anion gap of 20, but significant acidemia, had a PCO2 of 28. So with the high gap and the acidosis, we know that the primary disorder is an acidosis, and there's a metabolic acidosis of the high anion gap type. So that's the first thing. The second one is that the patient had an inadequate respiratory compensation. The PCO2, if you use the formula, should be between 18 and 22. His was 28, probably because he was stuporous. So not ventilating enough, so this is an inappropriate compensation, so the patient has a respiratory acidosis as well. And then the last one is that there was a greater change in bicarbonate. So, you know, the bicarbonate was dropped by 17, then the change in an ion gap. So actually, this is wrong. It's not a metabolic alkalosis. It's a metabolic acidosis. The patient had a metabolic acidosis from the diarrhea that was present. So it's not the highlighted green as D. The highlighted C is the correct answer. So the patient had underlying diarrhea causing a non-gap acidosis, developed a lactic acidosis on top of it, so that's a high gap acidosis, and because of the sedation and hypoventilation, had inappropriate, insufficient respiratory compensation. So the answer to that is C. Very good. Second question. 51-year-old man presents with 1 day of progressive confusion, slurred speech, and difficulty walking. He has long-standing Crohn's disease and has had multiple small bowel resections, most recently 4 weeks ago. On exam, his vital signs are normal. He is agitated, his speech is slurred and difficult to understand. His lab shows sodium of 141, potassium of 3.8, chloride of 110, bicarbonate of 10. The ABG has a pH of 717 with a PCO2 of 23. What is the best diagnostic test to define the etiology of his metabolic acidosis? A serum beta-hydroxybutyrate, a urine and ion gap, a serum methanol level, a serum D-lactate level, or a urine 5-oxoproline. Okay, serum D-lactate level, most people got. This is a classic, we'll get back to the case. It's a classic case of D-lactic acidosis in someone with short bowel or bacterial overgrowth or anything in that case, fluctuating, oscillating mental status with speech disturbances, with gait disturbances. So in someone with a high gap. It would have made the case easier if I had shown a normal or minimally elevated L-lactate or regular lactate level, if I had showed you normal glycemia, but the clinical case should give you the answer. So metabolic acidosis, how can you get there? You can get there primarily by 5 means. either you have, so you can have a decreased renal excretion, primarily through either impaired renal function or a renal tubular acidosis. You can have renal loss of bicarbonate, which is what happens in one of the renal tubular acidosis, the proximal type. You can have extra renal losses of bicarbonate, most of the cases either through diarrhea or through an upper pancreatobiliary fistula. You can have that through old pancreas transplants that were implanted onto the bladder. They don't do them anymore, but 20, 25 years ago, they were the primary means of implanting a transplant. You may see a patient still who has those. They excrete bicarbonate right into the bladder and have significant losses from there. And ileoconduits are not as bad as the old ureterosigmoidostomies, but they can also have significant bicarbonate losses in some patients. When you give too much chloride, you can induce a dilutional high chloride acidosis. And finally, you can increase the generation of metabolic acid, which is what happens with a variety of things, including lactate, D-lactate, keto acids, organic toxic alcohols, et cetera, et cetera. So the first step is to ask, what is the anion gap? If the anion gap is normal, you ask, is there dilution? Have you been given lots of fluids with chloride? Are there extra renal losses? Does the patient have an upper drain? Does the patient have a pancreas transplant, a ileoconduit? Does the patient have lots of diarrhea? And finally, you ask if the hydrogen secretion is normal, and the way you answer the hydrogen secretion is by looking at the urinary anion gap. And remember, to do that, you need to do only on patients who have acidemia, right? You don't look at the urine anion gap in someone with a normal, without knowing what the pH is. But in someone who's acidemic, the urine anion gap, which is the difference between sodium plus potassium and chloride, so should be, in most patients, 0 to 20. If you have diarrhea, you have an appropriate increase in ammonium excretion, and that will generate more chloride bound with the ammonium, so that will give a negative value. In RTAs, where you do not generate enough ammonium, you're unable to turn that urine anion gap negative, so you have a positive value. So that's how the urinary anion gap is used to determine if the urine hydrogen handling is appropriate. So if negative, the kidney is doing a good job. If positive, there's a renal problem in excreting acid, and that's very often what's seen with an RTA. Obviously, you would do this in someone who has normal renal function. If the renal function is abnormal, you typically ascribe it just to the renal failure. On the other hand, if the urinary anion gap is high, then you systematically have to rule out the causes of high anion gap, and you need to check an osmolar gap. So first, look at the anion gap, which is sodium minus chloride plus bicarbonate, or conceptually, anion gap is the unmeasured anions minus the unmeasured cations. So if you look at this Gamble-Graham here, you see that the anion gap is largely from the things that you're typically not measuring, or you're not entering into that measurement all the time. So it's from the cation side, it's mostly potassium, magnesium, and calcium. And from the anion side, it's phosphates, sulfates, organic anions, especially lactate and keto acids, and anionic proteins, especially albumin. So if you keep those in mind, you can see what the causes of high anion gap and low anion gap are. So you can see up on top that if you add several anions, that will increase the anion gap. If you have enough hyperphosphatemia or hypersulfatemia, as you see in renal failure, the gap will go up. Or if you decrease the cationic charge of plasma proteins, which is what happens in volume depletion causing alkalosis. One important caveat is that albumin lowers, so albumin is the most important component of the anionic side of the anion gap. So if you have lower albumin levels, you're going to have an anion gap that looks smaller. So that's important in patients in the ICU who have very low albumins, 1, 1.5. You need to remember to adjust for that. And the magic number is that for every gram per DL below 4 for the albumin, you should add about 2.5 milliequivalents per liter for the anion gap. So a guy with an albumin of 2, for example, you should add 5 to the anion gap to make sure that you're not failing to pick up an elevated anion gap. The updated, for those of you who like mnemonics, the updated mnemonic for high anion gap, so it's no longer mud piles, is Goldmark. And that helps you, so think about toxic alcohols, ethylene glycol, propylene glycol, methanol is further down in the M. O is oxoproline, pyroglutamic acid, typically in patients who are malnourished, taking a lot of Tylenol, especially if diabetic, so that's a relatively common, not relatively common, but we see it every now and then. Lactic acidosis, probably the most common of all of them. D-lactate in a patient like the one we reviewed in the case. Methanol, aspirin, renal failure, and all of the keto acids. And then we need to check the osmolar gap, because patients who have metabolic acidosis can have we always need to rule out the presence of a high osmolar gap. So when the measured osmolality is more than 10 milliosms per kilo above the calculated osmolality, the formula of which I put up there on top. And the things to remember whenever you see an osmolar gap are ethylene glycol, methanol, ethanol, obviously, propylene glycol, so especially in patients, primarily relevant in patients on Ativan drips, probably the most common thing. Etomidate, if you really give a lot of etomidate, but largely Ativan drips, and formaldehyde and paraldehyde. So getting back to the case, patient with multiple small bowel resections, agitation, speech abnormalities. The presentation is often intermittent, has a high anion gap, metabolic acidosis, has compensated acidemia. The amount of compensation of his PCO2 is appropriate. So if you check a serum D-lactate level, you would confirm that that's what the patient has. So why do we treat metabolic acidosis? Causes a lot of acute, or can produce some acute benefits, improving hemodynamic stability, improving myocardial performance, decreasing arrhythmogenesis. And then there's some chronic effects that are of lesser importance to you, but very important to us, which is decreased muscle catabolism and bone protection. So anytime you have a mineral acidosis, you have to replace. Now, whether replacing, correcting with alkali, lactic acidosis and DKA makes much less sense. What you have to do there is just revert the primary process. But whenever the problem is a primary loss of or failure to regenerate bicarbonate, then you would replace with alkali. If you decide to replace, then this is the roadmap. Basal requirements, about 1 to 1.5 milliequivalents per kilo per day. Treat the cause, essential for lactic and for DKA. And then my preference is always to use bicarbonate, and we give there the options. In patients on TPN, you can always maximize the amount of acetate, and if needed, you need to give bicarbonate dialysis. So it's telling me I have 6 minutes, okay. So for metabolic alkalosis, let's do this question. 60-year-old man with ischemic heart disease is admitted with decompensated CHF. After aggressive diuresis over 3 days, he's better. Medications include furosemide, ramipril, and carvedilol. Blood pressure is 122/58, heart rate 76. He still has bibasilar crackles and has some presacral and leg edema. Laboratory tests, sodium is 142, K33, chloride down to 86, bicarbonate up to 40, BUN 51, creatinine 1.5. His blood gas shows a pH of 7.55, a PO2 of 78, and a PCO2 of 41. What would be the most appropriate next treatment for him? A, you add spironolactone. B, you add chlorthalidone. C, you give him normal saline and potassium. D, you give him hydrochloric acid. Or E, you give him hemodialysis with low bicarbonate. Okay, very good. So most of you agree with me, the best treatment is spironolactone. He's developing significant metabolic alkalosis, and he is volume overloaded, so you can't give him normal saline and potassium. He's volume overloaded, can't do that. Chlorthalidone is going to worsen the metabolic alkalosis. Hydrochloric acid, you probably don't need to give it, and you need special arrangements with the hospital to get some, and he certainly doesn't need dialysis in the absence of renal failure. So how do you generate metabolic alkalosis? Well, it's either because you're losing hydrogen from the GI tract or from the kidneys, or you're retaining bicarbonate, usually because we are giving it to the patient too much and they cannot excrete. Or we're metabolizing organic acids, probably massive transfusion is the most important one here, or there's too much chloride loss, which is what happens in contraction alkalosis. Once you develop something that generates it, you got to maintain it, and what maintains it is the volume contraction, which decreases GFR, so you cannot dump bicarbonate, the chloride depletion, which keeps on sustaining bicarbonate regeneration, increased PCO2, hypokalemia, too much aldosterone around, and continued provision of sodium, which, especially diuretics, which allows the distal nephron to keep on regenerating lots of bicarbonate and not excreting acid. So these are the factors in the proximal tubule and in the distal tubule, in the distal nephron, that impact on that. And these are the factors that are operative in maintaining the metabolic alkalosis, and they are exactly the ones that we need to address when we want to successfully treat these patients. So when we were evaluating them, this is a busy slide, but it gives you a good idea of how to proceed. So in the history, you can obtain good evidence of what's going on in terms of sources of loss of bicarbonate, or retention of bicarbonate or loss of acid. In the physical exam, knowing if the patient, what the extracellular fluid volume status is very important. And then if you see here that the patient has a low extracellular fluid volume, then sometimes you have a clear cause from that. The patient has nausea, vomiting, if you can treat that, you resolve the problem. If the cause is unclear, so there's no apparent cause, then measuring the urine chloride is valuable. In patients who have a low urine chloride, less than 20, for example, then you got to think that the patient has a chloride depleting disorder, is losing chloride from somewhere else, and you just give chloride back as saline. On the other hand, if it's not easily corrected, then there are some hereditary disorders, probably the most important ones being Gittleman and Little's, but that's seldom an issue for you in the ICU. On the other hand, in patients who are either volume replete or outright volume overloaded, then if you have a clear history, patient with heart failure such as this one, heart failure receiving diuretics, then adding, then you can make the diagnosis, and the management will be with better volume management and the value of things like spironolactone or acetazolamide, which was not one of the options but was an acceptable option. The only problem with acetazolamide is that often as these patients are hypokalemic, you can really amplify the hypokalemia, and that's something concerning in the management of these patients. And if the cause is unclear in someone whose volume expanded, then you got to think of situations of mineralocorticoid excess or apparent mineralocorticoid excess. So things like primary aldosteronism, some hereditary disorders. The main example there would be Little syndrome. And that is evaluated by measuring aldosterone and renin. Again, more of a nephrologist chronic problem than an intensivist. The reasons why it's important to treat alkalemia is because it's toxic. Especially with pHs above 7.55 to 7.6, it's associated in at least 2 or 3 series with increased mortality. And you have several problems. You have hypoventilation. Sometimes it's tougher to wean patients from the vent. There are abnormalities in release of hemoglobin of oxygen from hemoglobin. Hypokalemia, decreased ionized calcium. There are some neuromuscular and some cardiac arrhythmic complications. So the way we treat it is by correcting those maintaining factors. And you can do that in someone who's volume depleted by replacing saline, in someone who's hypokalemic by replacing potassium. If someone is volume overloaded, you have freedom to dump bicarbonate, and you do that with acetazolamide, or you can also do that a little less efficiently with spironolactone or amiloride, but since this guy had heart failure, spironolactone would be particularly useful because of the other benefits that go beyond his alkalosis. Or you can give acid, or you can finally dialyze the patient with a low bicarbonate bath. So that was it for acid-base. Thank you.